be contribute more to the field. So, warm welcome and thank you once again. So we'll start the session first with Dr. Shivani's talk. She will talk today about the basics of hemophilia, how to approach a child with hemophilia, what to do, what not to do for the basic understanding. Following which, Mr. Dinesh will deal with the administration of factors, how to do a care from the nursing perspective. He'll be talking today. Dr. Shivani is the consultant pediatric hemato-oncologist at Choitram Hospital in Indore. And Mr. Dinesh is the senior nursing head at PGICH Noida, Delhi. So I hand over to Dr. Shivani. Please start the session. We request you to stick to 20 to 25 minutes. At the end of both the talks, we will have a question and answer session. All the participants, please post your queries in the chat box. We'll discuss at the end. Shivani.
Thank you so much, Dharani. Thank you for this opportunity. I'll be discussing basics overview of hemophilia and its management. And I think, Dharani, you need to make me host so that I can share my screen.
Yeah, I'll just. I'm not able to do it. Anyone from ECHO is there to help?
Not from ECHO side, I'm from PHO side, ma'am.
Hi, I think you are one of the hosts. Can you make her host? Because I'm only a co-host.
To whom I make to co-host?
Dr. Shivani Patel.
Okay.
Yeah, thank you.
Now Shivani Patel is co-host.
Thank you. Shivani, can you share now?
Still, I'm not able to. One second.
In the meantime, please make Mr. Dinesh also as co-host. Dinesh Pal.
Yes, done.
I'm not able to share my screen. I'm not getting that.
So should we make them host or?
Hello. Hello, ma'am. Let me know who is facing problem with screen sharing.
I am. This is Dr. Shivani. I'm not able to do that.
Please look into your screen.
Yeah.
In the bottom, you will have a screen share option, right?
Yeah, but I'm not getting that option. That's what I'm saying.
Okay. So, one second. Are you able to click screen share? Just try to click.
No, I can't see that option.
You can you share a screenshot on WhatsApp so I can see what you are seeing? Because I have given the access to everyone. Everybody can share their screen.
At what number I should send?
You might have opened the full window also. That can be possible. If you minimize the window and then again open it, then you might see the option in the bottom of it. There are options na, like participant chat.
Yeah, but in that there is the screen share option is not coming.
So you have joined through IECO, right?
Yeah.
Shivani, have you joined through the second link that I sent you?
Yeah.
No, you have to join through IECO, na? Then you will be able to share.
That's the same link I've joined through IECO.
Link.
Okay, I will log out and I will do that again.
Yeah, no, you don't have to join through a link. You have to join through the mail you have received na, on your phone. You have to join through that.
Okay.
Then you will be able to share screen. So
Okay.
you can leave and then join. Okay.
In the meantime, Mr. Dinesh, can you just try your link once if you are able to share?
Yeah, ma'am.
We shall just check with your audio and video one by the time Shivani is sorting her problem. Yeah, we are able to see your screen. Fine. Thank you.
Am I audible, ma'am?
Yeah. We can see your screen. Please stop sharing. We'll try with me. We'll have Dr. Shivani stop first. I just wanted you to check the process.
Okay, ma'am.
Thank you. ఎంత ప్రాబ్లం ఇస్తుంది अनुकृति, आपको मिला था मैम का स्क्रीनशॉट?
No, we haven't received any screenshot.
Okay, I am just sending you.
Please share. If anybody else has their slide.
Yeah, is it possible? Can you share the screen? Can I ask her to mail you?
Yeah. 1 second. Actually, I'm Manisha from ECO, and I have joined through the Anukriti's laptop because she's not here, so I'll not be able to share. If anybody else can share, ma'am, if you could share through your.
I will try. I will try. I will try. Yeah.
Yeah, because I have given access to everyone. So whoever joined through ECO can share.
Sure.
the-
Sure.
Yeah.
Sure. Yeah. Okay. Sincere apologies. Dr. Shivani is trying to sort out. So in the meantime, Mr. Dinesh, can I request you to start your session? We will have the orientation from your side. Then we
Okay.
will have completion of the session. Please start your screen. So just to give an overview, so we are doing the bleeding disorders first in this session. So it is just a basics of how to approach a child with a bleeding disorder and what are all the do's and don'ts that we should know, which will give better care for the patient and comfort to the parents as well. And we have chosen hemophilia because that's the most common bleeding disorder that we come across in pediatric hemato-oncology. Mr. Dinesh, please start. Thank you.
Am I audible?
Yes, you are audible now.
Yeah. Thank you, ma'am. I am Dinesh Pal, a senior nursing officer and nursing in charge in pediatric hemato-oncology, postgraduate institute of child health, Noida. Today we are going to discuss about the nursing aspects in hemophilia care. Basically, nurses play a vital role in providing comprehensive care to people with hemophilia and related disorder and coordinating care with other members of multidisciplinary teams, both with in the hospitals or in the community. So first one is a hemophilia. It's X-linked disorder, congenital inherited bleeding disorder of the clotting mechanism caused by an abnormal gene that produces a defective clotting factor protein with little or no clotting ability. बेसिकली टाइप्स ऑफ हीमोफीलिया के अंदर हमारे पास इसके अंदर हम बेसिकली वी आर ट्रीटिंग हीमोफीलिया ए, हीमोफीलिया बी. Hemophilia is a factor VIII deficiency and it is X-linked recessive caused by the functional plasma and deficiency of functional plasma clotting factors, which may be inherited or arise from spontaneous. That is, second one is hemophilia B, factor 9 deficiency. This is also X-linked recessive. Hemophilia C, factor 11 deficiency, and parahemophilia or von Willebrand diseases. So treating team, basically in this we have a multidisciplinary team like doctors, like pediatric hematologist, pediatricians, nurse, basically the crucial member of the team, musculoskeletal experts like orthopedicians, rheumatologists, occupational therapists, laboratory persons, psychological experts, specialists on demands like dentist, geneticist, hepatologist, infectious disease specialist, immunologist, etc. Am I audible? Am I audible?
Yes, you are audible.
Yes,
Okay.
yes, you are.
So the medical management part will be taken by Dr. Shivani. I will take the nursing management part of nursing care of hemophilia. So basically, we have set some nursing problem priorities in the hemophilic patient like bleeding. First one is the bleeding prevention and management. Second one is the monitor for signs of bleeding complications, administration of clotting factor replacement therapy, administration, injury prevention and self-care measures, pain management during bleeding episodes, promote physical mobility and joint protection, ensure compliance with the treatment plans and medication regimens. So first one, when the patient comes with us in the hospital, when the patient reach in the hospital, the nurses should assess the sites of bleeding, or a nursing assessment should be include to check the joint tenderness, swelling, or limited range of motion due to hemoarthritis, presence of ecchymosis or hematoma, gum bleeding, epistaxis, blood in urine or stool, excessive bleeding during menstruation, excessive bleeding following dental procedures or minor trauma, unexplained or prolonged bleeding after vaccination. So what should we do for preventing bleeding risk and injuries? Basically, the children with hemophilia are at risk for injury due to the decreased concentration of clotting factors in their blood. There is a greater risk of physical injuries such as bruises, cuts, and joint bleeds. Can lead to a pain and limited mobility. Many patients are aware of bleeding in joints before bleed start. This feeling is called aura. Joint hemorrhage, hemorrhages include pain, swelling, rapid loss of movement, aura. Aura is unusual tingling-like sensation in the joint, warm skin, tightness within the joint. So for prevention of bleeding, what should we do? Avoid trauma and contact sports, avoid drugs that affect platelet function, good oral hygiene, regular exercises. So young children, basically young children, infant children should be avoid fall from bed. We should make the bedding on the floor if possible. Leave child always under supervision of an adult. Careful while applying soap, oil, prevent slipping from hand. We should utilize appropriate toys for the in child's soft toys. The toys should not be pointed or sharp, and we should not give small sharp objects to the child. For infants, may need to use padded bed rails, side rails on the crib. We can use pillows also. In the hospital setting, we should never check the rectal temperature of the hemophilic patients. All of these recommendations will minimize and prevent bleeding episodes due to trauma. Then advise adolescents to use an electric shaver versus manual razor devices. A high risk of bleeding is related to the use of razor blades. A minimal risk of bleeding is associated with the use of an electric shaver. And we should also take care for the dental hygiene of the child's. Very important to prevent bleeding from gums. Brush teeth daily. We should advise gargling. Mouthwash also may be used. Use soft toothbrushes is important. One thing that kept in mind, should people with bleeding disorder participate in sports and exercise? Yes, the patient can participate in sports and exercise. Basically, the regular physical activity can increase joint stability, function, reduce the risk of injury, and improve quality of life. It builds healthy muscles, bones, joints. It also improves the self-esteem, lean body mass, and that it increases the energy level and reduces weight, depression, or anxiety, or risk of metabolic syndrome, etc. Physical activities we can advise the patient. The patient can do like swimming, yoga, bicycling with helmets. So, and after taking prevention, we should managing. What should we do for manage the acute bleeds? This is completely from the nursing side. We should follow the price. We all know protection. Protection means splinting of the part, rest, ice, compression, and elevation. So for splinting for muscles and joint bleeds and superficial bleeds, first aid for slowing bleeding and thus reducing pain. For the in the rest part, give rest to the affected limb. Arm के अंदर, elbow, shoulder, wrist. Use a sling. Do not lift weights, carry objects. We can advise to the patients. Or in the leg, hip, knee, ankle, do not bear weight. Then second point was eyes. Eye means eyes and immunizations. So eyes reduce pain and spasm of the muscle, reduce swelling and inflammation. Crush eyes and put it in a plastic bag or cover with a towel. Never put in the eyes directly to the affected area. Do not, especially in open wounds, do not use it for more than 15 minutes. Ice packs, crushed ice packs in plastic packs. We can use cold packs, gel packs, can wrap it around a thin kerchief, molds around the joint. Then ice massage around the joint we can do for several minutes. Ice bath means dip the foot, hand for 2 to 3 minutes. Reduce bleeding, reduce the joint space, etc. For compression, we use elastic bandages, elastic sleeves, but it is very important. Am I audible? Am I audible?
Yes.
How to apply a compression bandage? It is very important how to apply. Start below the joint. This cross pattern stop above the joint, should not be too tight, and watch the color change, temperature change below the bandage on the regular basis. Last one is encourage physiotherapy. Patient with hemophilia should be encouraged to do daily physical activities. And advise regarding special exercises if needed. During acute bleed, do not move the joint for next 1 to 3 days depending on pain. But the physiotherapy must be continued for other joints if one joint has bleed. And now the administration of clotting factor replacement therapy. Factor used commonly: hemophilia A, factor VIII recombinant or plasma derived; hemophilia B, factor VIII recombinant or plasma derived; inhibitor positive hemophilia A, factor VIIa, FEBA, emicizumab; inhibitor positive hemophilia B, factor VIIa or emicizumab; von Willebrand disease, VWF containing factor VIII; rare bleeding disorders, factor VIII, fibrinogen, etc. Important points when before giving a factor, dose is calculated by the physician, but we should keep in mind dose is calculated as per demand for prophylaxis, site of bleeding, type of hemophilia. Check the dose. Very important for nurses. Check the dose charted in the prescription slip. Check name of clotting factor, vial, strength, number of vials, and prescription date is also very important. Check for the expiry and for the factors also. Basically, infusion of factor is a simple process which can be done easily, but in a well-mannered way under aseptic technique. First one, before doing any procedure, wash hands is necessary. So first do hand wash. Before arranging and after arranging articles, we should wash hands thoroughly by your infection control protocol. We can follow our hospital infection control protocol, or we can follow WHO guidelines for hand washing before and after procedure. Get the material ready. Basically, material should be ready on a clean, flat surface, preferably have a soft cloth or tray, which may include tourniquet, filters, alcohol swabs, bandages, gauze pieces, butterfly, cannula, or factor. Third, take the contents out of the factor pack, which contains the factors, syringes, and different type of filters we can get in the different type of factors. Then getting the factor ready for infusion constitution. First one, when we take the factors from the refrigerator, warm the unopened vial containing solvent on room temperature. After warm the vial, remove the factor vial and diluent vial's protection cap. Please use alcohol swabs to disinfect the top of the vial. Remove the cap of the short end. Remove the cap of the short end of the needle and insert into the diluent vial. And then remove the cap of long edge of the needle and insert rapidly into the factor vial. Diluent vial must be on the top of the vial and water will flow from the diluent to the factor vial. Remove the needle from the factor vial. Mix the content by gently rolling the factor vial between the hands. Don't shake, it may damage the factor. Be sure the factor is completely dissolved. Otherwise, active material will be removed by the filter. The important thing, do not refrigerate after reconstitution. Attach the filter to the factor vial and withdraw the content into the syringe. Basically, attach the filter or filter needle to the syringe. Never take the factor directly into the syringe without filter. It is very important. We should always use the filters. Filters are mostly provided by the company, which company's factor we used. When our factor is ready for infusion, then we cannulate the patient, use butterfly or cannula in infants, neonates, and patients with repeated doses admitted and OPD. Wash your hands, wear gloves, hold child still in infants, or use any kind of distraction for cannulation if needed. Explain the procedure to the patient, and if the child very small, then to her parent. Insert the butterfly or cannula into the vein. Points to be remembered while cannulation. Always assess a vein first before pricking the vein. Assess the vein and always try to feel the vein rather than look. Our patients are regular patients for infusion, so they know the veins better than us. So don't hesitate to ask your patient about the prominent vein of the hand or extremities. Use an butterfly or appropriate cannula site. Insert at the non-dominant hand first. Start with distal veins and work proximally. Then apply tourniquet correctly. The tourniquet should be placed tightly, hinder venous flow, but not too high to impact arterial flow. Feel for the radial pulse within the tourniquet in place. If you cannot palpate it, your tourniquet is too tight. Puncture without a tourniquet if the patient has adequately filled but fragile veins. Proceed with the insertion without using a tourniquet. Pressure from the placement of the tourniquet may cause the client delicate vein to blow out upon punctures. For in the cannulation, rather than slapping, flick or tap the vein, we should use this technique because use your thumb and second finger to flick the vein. Slapping may collapse the vein, so we should use flick and technique. Now, take care of the veins. For hemophilia patients, vein are the lifelines for that type of patients. 23 or 25 gauge butterfly needles are recommended for breaking. Never cut down into a vein except in an emergency. Apply pressure for 3 to 5 minutes after venipuncture. Venous access devices should be avoided whenever possible. And we should one thing kept in mind when we done venipuncture by the butterfly, never give pressure at the time of mm, butterfly removal. It may damage the vein. This is the and basically IV cannulocytes. We all know about this. So for capting, for refrigerating of factor 9, factor 8, all factors recommendations are nearly same. Basically, all factors should be stored in 2 to 8 degrees Celsius. We should not freeze. To be reconstituted only immediately before administration because it does not contain any preservatives. Reconstituted materials should be used immediately. If not used immediately, we can use it up to 3 hours at temperature up to 25 degrees Celsius. Reconstituted product must not be returned to a refrigerator. Only the provided infusion set to be used. Factor must be slowly intravenously, maximum rate is 2 ml per minute. Ask the patient to stay in the hospital for at least 20 to 30 minutes after infusion and watch for hypersensitivity reaction may include rash, hives, itching, facial swelling, tightness of chest and wheezing. Factor 8, same 2 to 8 degrees Celsius store and we can use it up to 3 hours at temperature after reconstitution. Reconstituted solution should be inspected visually for any particles before administration. The solution should be clear to slide clearly and colorless if it is not discarded. Infuse the factor over several minutes. Ask the patient to stay in the hospital for at least 20 to 30 minutes. FIBA. And basically, FIBA all same should be stored in 2 to 8 degrees Celsius. And do not exceed an infusion rate of 2 units of FIBA per kg of body weight per minute. Patient should stay in hospital for at least 20 to 30 minutes after infusion. Imacizumab is a non-factor replacement therapy used for hemophilia A. It is injected subcutaneously to prevent or reduce bleeding episodes, but is not used to treat bleeding. Do not shake any factor. Once removed from refrigerator, unopened vial can be kept on room temperature up to 7 days. Take home messages is nursing in hemophilia care center have a vital role in counseling and treating. Parents should be counseled on how to prevent trauma. Early management of bleeding can help reduce disability. Thank you.
Thanks a lot, Mr. Dinesh. It was a wonderful talk. You have given the practical aspects very beautifully. So I will have Dr. Shivani's talk as well and finally have some questions at the end. So Dr. Shivani, will be able to share the screen or shall I?
You share the screen.
Yeah, sure. Yeah, just give me 2.
So, sorry everyone for the entire fiasco with the slides. And Mr. Dinesh has covered very well the practical aspects of management. I think half of my talk he's covered in detail how to administer factors and what to be done with these patients. So, what I'll be discussing mainly is what is the basic pathophysiology of hemophilia, why do they bleed, and how do these patients present to us, and what else we can do for management, and what are the complications which we see during their treatment. Dani, you're able to share?
Hello.
What problem you are facing?
Dharni?
We can see your screen now.
Dani, come to the next slide, please. Okay, so what is basically a bleeding disorder where the normal hemostatic mechanism of your body is disturbed that leads to bleeding. So to understand hemophilia, we need to understand what are the basic component of our hemostatic mechanism. So we need all these 5 things to form a clot in our body. First is platelet, then anticoagulant protein, procoagulant protein, fibrinolytic system, and the intact vessel wall. Next slide, please. So whenever there is a vascular injury, first response of our body is vasoconstriction. The vessel will constrict and it will start activating the platelet. So the first response is formation of a platelet plug. This is called as primary hemostasis. Then this activated platelet will turn on the coagulation cascade and form a blood clot, which is more stable, and it is called a secondary hemostasis. So there are 13 clotting factors in our body which are required to form this stable clot. Once the clot is formed, then our body's natural fibrinolytic system starts degrading the clot. Otherwise, the clot will just keep on extending, and we don't want that. Next slide, please. So we need all 13. Even if one factor is missing, the clot will not form properly and bleeding will continue. Next. So hemophilia, as Mr. Dinesh has rightly told, that it is a genetic disorder. It is inherited. We inherit it from our parents. And the most common hemophilias are due to deficiency of factor 8 and factor 9. The deficiency of factor 8 is called as hemophilia A, and deficiency of factor 9 is called as hemophilia B. So it is an X-linked recessive disorder. That means that females are the carriers. Female carry the gene, but males are affected because females have 2 X chromosomes. So one is normal, one is disease. So they have 50% level. But the males have only 1 X chromosome, so they are going to be affected. But always remember that being an inherited disease, 30% of the patients will not have any family history because they develop mutation in utero de novo when the fetus is in uterus. Next. So hemophilia is a lifelong disease. It is a genetic disease. You can't change the course. So once you are born with hemophilia, you live with it. It's going to be a lifelong. It's a chronic disease. So how do you diagnose hemophilia is through most important clinical feature. They usually come with a positive family history. You have to inquire if there are any male relatives in the maternal side of the family are affected. They'll present to you with excessive or prolonged bleeding. So normally during anyone's lifetime, there are certain hemostatic challenges which you present with. So even if the patient has come to you for the first time, you can elicit a careful history and ask them, was there a prolonged bleed during birth when the umbilical cord was shed? Or there was a huge cephalohematoma during a forceps or vacuum delivery. Whether there was prolonged bleed during common surgeries which happened during childhood, like circumcision or tonsillectomy, or and every child is going to receive routine immunization. So during vaccination, if they have huge hematomas, that means they are bleeders are more prone to have a bleeding disorder, or there is bleeding following dental exfoliation. Next. So the most common site of bleeding in hemophilia are joint and muscle. So in infancy, usually when they start walking, we start seeing the manifestation. They'll come with either ankle or knee joint bleeding. Next, please. So most common are joint and deep muscle bleed, but the life-threatening bleed like intracranial bleed, gastrointestinal in the form of massive hematemesis, melena, or bleeding in the neck and throat, which can cause airway compression and difficulty in breathing. These can also present, but these are rarer. Next. So these are some of the manifestations, like you're seeing in the first picture is the forearm where the muscle, deep intramuscular bleed is there. There is a knee and elbow joint bleeding. This is a picture showing the prolonged bleeding from an umbilical stump. Next. So how do we diagnose? Whenever we see a patient with a history of prolonged bleeding, we order a hemostatic screen. If the CBC platelet count is normal, then next test which we do is prothrombin time and APTT. In hemophilia, APTT is prolonged. This you have to remember. And how do you diagnose is there will be deficiency of factor, either 8 or 9, whichever is missing. So what we have to remember is to collect the sample correctly. If this sample is not correctly taken, then we'll not get the test correct, and we cannot interpret them. So we all have seen this tube. This is a citrate tube. There is an anticoagulant already present in this tube, and up to the mark we have to fill the blood, not more, not less. If we fill that up to the mark, then only the ratio will of 1:9 will be correct. We should not draw this sample from an indwelling lines where we use heparin flushes for central lines, PIC lines and all. We should not collect this sample from that. So if we take the proper sample, then only we are going to get a correct result. Next slide. So severity and diagnosis of hemophilia is based on the level of factor. All of us have normal factor level between 50 to 150 percentage. If it is less than that, then we call it as hemophilia. Factor level less than 1% is severe hemophilia. They spontaneously bleed without any trauma, without any trigger also they can bleed. Factor level 1 to 5 is moderate hemophilia. They have just occasional bleeding, not so frequent. More than 5%, they are mild hemophilia. They rarely bleed unless they have undergone a major surgery or any trauma. So what are the patients who are going to come with a spontaneous bleed are severe hemophilia. Next slide. So next slide. Management of hemophilia, as Mr. Dinesh has rightly pointed out, it's a multidisciplinary approach. Not one person can do the job. Patient, family, and including a team of doctors, nurses, psychologists, everyone is needed, because we have to take care of physical as well as psychosocial health. It's a chronic disease, so we have to give them the best possible quality of life. Next slide. So in how do we proceed with treating is, our goal of therapy is, first is whenever the person has come with a acute bleed, to prompt management of the acute bleeding. Next, an important thing is prevent further bleeding and joint damage. And third thing is management of complication, and also to promote the psychosocial health. You have to also look at the psychological aspect of the disease. Next. So this Mr. Dinesh has rightly covered that as soon as a patient recognizes that there is a bleed, usually the patient will get a aura that before the bleeding appears. So at home, what they can do is price, which he's covered in detail, so I'll not go through it. Only thing we need to remember is in the step where we are putting cold compression, we should not apply it directly, either with covered with some towel or something like that, and we should not put it in the cut or open wound. If you feel that there is poor circulation, the sensations are not felt over that portion, there is a weakness, you should not put cold compression directly. Next slide. So the treatment of bleed, how we do is first we have done first aid at home, then you need to give the factor concentrate as soon as the patient appears in the ER. Then along with that you also have to give the pain management and antifibrinolytic. Next. So bleed should be treated quickly, and the quickly you treat, the quickly it heals, and the chances of joint damage are very, very late. The longer you take the time, the longer it takes time to heal. So whenever in doubt, even if you have not proven that this is a bleed, somebody has come with a symptom of a swelling anywhere in the body, a hemophilia, consider it as bleeding and treat. Do not wait for the symptoms or any investigations. Next slide. So what is important is factor replacement therapy. So what we do is the time, as I said, we have to treat it very quickly. So time of initiation of factor is very, very important. So how, what we tell our patients is usually to keep the first dose vial with themselves, so that whenever they come to emergency, they come with a vial in their hand. They should have their, whenever they are traveling or when they are not in the town, not with their hospital, they should have their identity card or their file which says that they have this particular factor deficiency, and along with them they should have their emergency instructions written. Next slide. So we can replace factor in many forms. Previously, we used to use fresh frozen plasma and cryoprecipitate. Nowadays also we can use, this is a blood product. So it has its own risk of transfusion associated lung injury, or it causes higher chances of viral transmission of viral infections. So for hemophilia A, you can use cryoprecipitate and FFP both, but for hemophilia B factor 9, you use only FFP. We use more specific factor concentrate nowadays. There can be either two types which are available in the market. One is plasma derived, which is made from human plasma, and another is recombinant, which are synthetic. So both type of factors are available. Next slide. So factor infusion, that Mr. Dinesh has taken in detail how we should be given, what all precautions we should take. Important aspect is the dose calculation. So every unit of factor given will raise the factor level by 2 units. Okay. So we want the dose of the factor is calculated, factor 8 is calculated like 0.5 into weight into desired factor level. The desired factor level activity depends on the type of bleed. If it's a life-threatening bleed like intracranial, we want 100% activity. If it's a minor bleed, then 40 to 50% activity is enough. So remember that factor 8 half-life is 12. So this has to be given twice a day, whereas factor 9 has a longer half-life, so it is given once a day. Next slide. Apart from that, you have to take care of the inflammation and pain. So paracetamol is a drug of choice. We try to avoid NSAID and aspirin because that also causes platelet dysfunction and they can increase the chance of bleeding. Antifibrinolytic like tranexamic acid also we should be giving to the patients, and only place where tranexamic acid is contraindicated if the patient is having hematuria. Next slide. Once the patient is stable, once the pain is gone, swelling is not there, then we should immediately start them on physiotherapy. It helps to strengthen muscle, restore the joint movement, and safe return to the normal activity. So this is very, very important. Often patients come for the acute bleed, but they never follow up with the physiotherapy department, and it has to be continued. Otherwise, we will have more long-term joint-related problems. Next slide. So prophylaxis, this is another modality of treatment. What we saw is on-demand treatment. Whenever the patient come with bleed, we treat them. So we saw, depending on the factor level, that only severe hemophilia will come with spontaneous bleeding. Mild and moderate will occasionally bleed. They will not come with a spontaneous bleeding. So what if we convert a severe hemophilia into mild or moderate hemophilia? So how we do is we, as soon as the patient is diagnosed, we put them into regular 2 to 3 times a week factor prophylaxis, so that their factor level is always maintained between 2 to 3%. At 2 to 3%, they are like moderate hemophilia. They are not going to have a spontaneous bleed. But the cost of giving factors regularly is too high. So most of the time it is not possible with us. Next slide. So apart from this thing, there are a lot of general management which we ask them to do. Vaccinations have to be done regularly, and vaccinations to we have to tell them to take it subcutaneously rather than intramuscular to prevent bleed. Yearly screening of transfusion transmitted infection, and general nutrition and physical fitness they have to build. Next slide. Next slide. So we also have to teach them to prevent bleeding. So there are a lot of lifestyle changes, as we have already covered, that they should be participating into regular sport activity, which are less prone to bleeding, like swimming, cycling, with appropriate gearing, like a helmet, protective knee pads, and all. So contact sports should be avoided. Regular physical activity is must to preserve the normal musculoskeletal function. Next slide. So what happens if you have, let's look at the complications of the bleed. If you have a recurrent joint bleed, then they form target joint, and what is called as hemophilic arthropathy. So they will have different type of joint deformities. Next slide. Next. So, because of recurrent joint bleeding, they can develop flexion contractions, they can develop arthropathy, chronic pain, muscle atrophy. Next slide. These are the various images which shows, muscle atrophy, chronic swelling, chronic arthropathy, fixed fracture deformity, and ultimately they lead to joint destruction. Next please. So we need to prevent all of these complications and treat them appropriately at the right time. Another dreaded complication is development of inhibitors. So what happens is, when we are replacing the factor regularly, our immune system tend to form antibodies against that factors, and then those factors no longer work in our body. So even if you are giving factor VIII from outside, the antibodies will block the coagulation cascade and clot will not form. So these patients have to be screened regularly for the presence of inhibitors, and in that case we cannot use factor VIII or IX for the treatment. There we have to use factor VIII bypassing agents like FIBA. Next slide. So, having said all of this, prevention is the most important thing which we must all emphasize, because this disease is preventable. It is a genetic disease. We can counsel the high-risk couples, and even in the child who's been affected, the couple can be counseled for the next pregnancy, that in the first 3 months of pregnancy, we can do the fetal sampling, check the fetus if it is disease is present, and we can offer them termination. So we whenever there is an opportunity, we should counsel them for a prenatal diagnosis and prevention of the disease. Next slide. So these are a few messages which I would like to give, that spontaneous bleed is seen in severe hemophilia. Of all the bleeding, joint and deep muscle are the most common ones. uh, Early you treat, earlier the recovery, and you can prevent the damage. So whenever in doubt, just treat, just give the first dose of the factor. The next dose will come only after 12 hours. You have 12 hours to think and decide what further you have to do. Initiate physiotherapy once the pain subsides. This is often neglected. So as soon as the patient is better, the joint bleed is gone, swelling is gone, pain is better, they go back to being their normal routine and do ignore the physiotherapy part, but that has to be continued, and it is preventable. So whenever opportunity, we should counsel them for the prenatal diagnosis. Thank you.
Thank you, Shivani, for the wonderful talk. So I request all the participants, please post their questions on the chat box if they have any. So, Mr. Dinesh, do you want to add any comments? I have one question to both of you commonly after you add. So there was a practice earlier that we were even using expired vials of factor VIII because it's very expensive. And we used to assume that whatever factor remaining will be of some help. So is that a practice still now also in your centers or across anywhere you've come across? This is question common to both of you. Yeah, please, Dinesh.
So, shall I
Yes,
say
Shivani.
something? Yeah.
Yeah.
So it's I think it's kind of a more of a desperate measure. I mean, if we have nothing to give, then might as well give the expired factor for whatever benefit, because it's still better than using the blood product plasma or cryoprecipitate. So most of the times in hemophilia society, through hemophilia societies in the district hospital and all, there are often expired factors available, and we have used it. We do not prefer or recommend that, but yeah, in desperate situation we have used it.
In our center, madam, in our center, we never use expired vials. I never seen this type of practice in our center.
Yeah, right. So I think now we are actually having many NGOs and the hemophilia societies getting many resources to arrange all the factors. This was a practice I am talking about, which I have come across 10 years ago. Of course, not this date, but still, as Shivani said, when you are desperate, and it's better than the blood products, is what we think. And there's a one question which I would address to Shivani. Which factor is most suitable? I think they're asking whether it's plasma derived or recombinant. So
So I think it's not much of a choice, but yeah, recombinant is better because it's the chances of viral transmitted infection is even minimal with that. With plasma derived, it is still there. They are inactivated plasma, so it's not 0% in that. But given a choice, recombinant is preferred over plasma derived.
yeah, thank you. So Mr. Dinesh, sorry I cut you in. You had any other points to make?
Yeah, basically, so should motivate all the patient for, and we should train about for all the patient of for self infusion of factors, which is very important. Self infusion technique is very important for a a good or better life for the patient. So we should motivate, we should train for all the hemophilic patients after age of 3 to 4 years for self infusion of factors.
Yeah, I completely agree too. In fact, teaching the parents to do that again is a wonderful thing. But for some reason, in the place where I practice, we have never come across such a situation. So only thing is we always encourage, I mean, they come to ER and get it done. So the main point for the nursing is to be as like any chronic disease, this is a very frustrating situation for the parents. So, in fact, coming, I mean, very frequently to the hospital, getting injections to the child. Mr. Dinesh very rightly pointed out that they will have significant IV line difficulties. Again and again we poke. So this is definitely a huge psychological issue as well. So, as doctors, as nurses, it's very important that we address those aspects as well. And a few aspects, few practical aspects, like not putting a tourniquet or a very great pressure to which can even create a hematoma. All these simple things we have to take care. Uh, I mean, once we remove the IV cannula, it's always better to give a deep pressure for 10 minutes and then put a tight plaster before we send them. How often we have had a situation last week in our own ward when there was a child with factor 10 deficiency. They've removed the cannula, the child just moved the limb, and there was a huge outpouring of blood, which is not a very pleasant sight for anyone to see. And being a small child, the parents always panic. So these simple things will always make their lives much better. And this is the least that we can give to these children and their suffering families. So, if there are no more questions, I sincerely thank Dr. Shivani and Mr. Dinesh for their wonderful presentation and their time to teach the session. And I thank everyone for joining and staying till the end. We'll close the session. Thank you very much.
Thank you so much.
पर्सनली मांगने की क्या जरूरत पड़े।
उसने रजिस्टर नहीं कराया था, ऐसे तो मैं मांग रहा था।
अच्छा,
हम्म,
ये सही है ना, देखिए जरा।
ये कर
मैंने ये ऐसे लिख के ऐसे लिख दिया है सारा,
उसको thank you
जो
बोलो।
खराब खराब चीजें हैं।
थैंक यू।
अच्छा, थैंक यू।
लड़की को थैंक यू।
ओ माय गॉड, पर्सनली थैंक यू हमें लगा इसमें थैंक यू बोलो। आप